Femoral shaft fractures. Anatomy. The femoral shaft is the diaphysis of the femur, extending from the isthmus to 5 cm proximal to the adductor tubercle. The femur has an anterior bow, with the medial cortex under compression and the lateral cortex under tension. Deforming muscle forces. Proximal fragment. Abducted by the glutae, flexed by the iliopsoas, extended by the gastrocnemius, externally rotated by the rotators. Distal fragment. Adducted by the adductors. Classification. 1. AU classification. Type O, non-displaced fracture. Type 1, simple, undisplaced fracture. Type 2, fracture with displacement but without comminution. Type 3, comminuted fracture with fragments. Type 4, open fracture. 2. Winquist and Hansen classification, based on comminution, useful for interlocking nail decision. Type 1, minimal or no comminution. Type 2, cortices of both fragments at least 50% intact. Type 3, 50% to 100% cortical comminution. Type 4, circumferential comminution with no cortical contact at the fracture site. Treatment. 1. Conservative management. Indications. Children, unfit for surgery. Methods. Traction. 6 to 8 weeks, followed by long leg cast for the distal half. Hip spica for the proximal half. Traction types. Thomas splint or skeletal traction using 15% of body weight, rule of thumb. Pin placement. For distal femur from medial to lateral, adductor canal avoid, and proximal tibia from lateral to medial, common perineal avoid, ensuring direct control on fragments and avoiding quadriceps scarring, especially in cases with ligamentous knee injury. 2. Operative management. Antegrade intramedullary nail, IMN. Indications. Gold standard for femoral shaft fractures. Entry points. Piriformis fossa, collinear with the femoral shaft, or trochanteric, easier to identify. Reaming. Reamed or unreamed nails, using larger nails to control intramedullary pressure and improve union rates. Locking. Proximal and distal locking screws to control rotation and maintain length in comminuted fractures. Retrograde intramedullary nail, IMN. Indications. Floating knee, distal femoral fractures, pre-existing proximal femur hardware, or difficult positioning, e.g., obesity, pregnancy, unstable spine injury, bilateral femoral fractures. Contraindications. Restricted knee motion less than 60 degrees, patella baja, open fractures, knee sepsis. Entry point, intercondylar notch. Puncture nail, historical. Indications. Transverse or short oblique fractures near the isthmus with minimal comminution. Flexible IMN. Nancy nail, used in children for more flexible treatment options. Open reduction and internal fixation, ORIF. Indications. Proximal or distal extension, narrow or obliterated medulla, associated vascular injury. Methods. Broad dynamic compression plate, DCP, 4.5 mm, with at least 8 cortices above and below. External fixation. Indications. Similar to ORIF, including the conversion to IMN within 2 to 3 weeks. Special considerations for ipsilateral femoral neck and shaft fractures. Treatment options. Recon nail. Screws for neck and plate for shaft, or retrograde nail for shaft with screws for the neck. Dynamic hip screw, DHS, for neck and retrograde nail for the shaft. Complications. Neurological, vascular injury. Damage to nerves or blood vessels. Infection. Due to open fractures or surgical intervention. Compartment syndrome. Increased pressure in muscle compartments leading to tissue damage.